HIV service integration is basically the convergence of services for a holistic person, mainly at this time focusing on a person living with HIV or at a high risk of HIV in line with the NASCOP focus. So in the context of the current epidemic and response, we have about 1.3 million Kenyans who are accessing care in our health facilities, majority of whom access services at primary health care, over 90% from level 4 to level 2. This population also, over 65% are aged above 35 years. Now, that combination tells you that beyond HIV, they have other health needs. And so to be responsive as a program, to be responsive as a ministry, to be responsive as a service delivery point, you need to redesign your services to respond to the multiple needs that the person requires beyond HIV services. And so the service delivery, the integration is really a focus on the person rather than just the virus that the person may have acquired or is at high risk.
Personally, I'm so much elated and happy that Kenya as a country has taken a key stride in bringing us together to talk about HIV integration into other services. You know, HIV has been quite a vertical program that was like disease specific. Everything, the training, systems, EMRs was specifically disease specific. But we want to look at a way, how can we integrate all this?
As people are living, they're also growing older. And also as they're using those drugs, there are issues that are emerging. You know, in the order of things, staying alive was number one, then the quality of life. But then now some of the side effects of drugs over a long time start manifesting. So they will manifest, for example, hypertension or diabetes. They are some of the problems of the cancers that we've had. It's important that this person who's HIV infected is not just treated for the HIV, you actually treat him as a whole person. All his needs are important.
How it looks like today, when we look at our patient information and outcomes, is you have the 50-year-old that you've asked, virally suppressed. In other words, viral load is undetectable, successful HIV. But that same person who screened them, they have hypertension, diabetes that is not controlled. And so the person will walk out of your clinic with no virus, but will be killed or will die because of uncontrolled hypertension and diabetes. So the future of a successful intervention or integration will be the virus is controlled, the hypertension is controlled, and the diabetes is controlled as they walk out of that facility. Today, you have a healthcare worker who knows so much about HIV that you go see them in a separate place, but very little focus on the other issues that are surrounding the person. I look forward, so in other words, you then have to get another healthcare worker to deal with the mental health issue, to deal with the hypertension. So I see a future of integration where a trained healthcare worker at a primary healthcare level to provide an integrated person-centered, so that when you see a healthcare worker, it's not a HIV healthcare worker, it's a healthcare worker who provides services for you depending on your needs, and you walk out from one healthcare provider. Today, the data systems for HIV, we are able to say so much about the person who is living with HIV, including how they are aging, when did they come to take drugs, but not so much about the other conditions. So I look for an integrated future where I can tell the story of a client from whatever their needs are, not just for HIV, because the facilities are the same. So leveraging on that infrastructure. And so there are many positive futures as we have discussions around integration, including laboratory diagnostics. The same platforms we use for HIV trust me, they can do HPV, which is cancer screening and diagnosis. The same platforms can do much more than what we are using. So integration also gives a chance for the other conditions to leverage on the investments for a proper person-centered.
We want to leverage the way we are doing now viral load testing, that we have centralized testing, where samples are referred to this molecular testing in the 12 testing labs in country. But at the moment, to support VIC on the USC agenda, we are decentralizing services to the counties. HIV testing viral load happened in mostly in research facilities, and we are removing or transitioning it to the public institution, where sustainability can be taken through by the county. The county or the facility can be able to utilize the equipment using the same one human resource, which can do HIV, but can also do other diseases using the same equipment. The turnaround time can be reduced because as we move it service nearer to the people, the time of getting results from testing to the service provider is reduced. Sometimes if leveraging on opportunities which is already there, the infrastructure, the county owning it makes it easier for incorporating other tests.
Kenya is one of the countries to shape the Global Alliance agenda to end AIDS in children by 2030. And for us to end AIDS in children, we really need to have integration along several areas of service delivery, including immunization of children, including medical services for children, because those are areas where we can actually leverage on to identify children who are HIV positive, alongside prevention of mother-to-child transmission, which includes prevention of new infections to the mothers as well.
How prepared are we? I think this summit and what has been preceding the discussion is a reflection of what is happening at the global level. Both at the global, national level and country level, really is a beginning of a conversation, an incremental discussion around integration that has been there, but now it's more pronounced because the reality is that we're not providing quality programming. And so at the global level, it's more of consultations. So we are prepared because we have brought counties here. We have all the 47 counties here. As service delivery units, they are telling us, we saw that problem. We have tried some solutions, and maybe we could synthesize that and then scale up for the purposes of client. So we are prepared to sit together to define policies that then are responsive to the context and the country reality. Secondly, there is WHO guidance that has been given around primary healthcare and HIV convergence or integration. That is an important tool because it does provide tools and guidance on what we can do and adapt as a country. Thirdly, I say for Kenya, it's the best time because the things we are discussing are practically possible in the context of UHC rollout.
Every disease, as it progresses, people re-engineer and think of how best we can be able to maximize on the little resources we have. And then how can we be able to also address other emerging diseases within that space. So and then with the resources also dwindling, then you must think of how do you keep your population healthy.
Can integration of NCDs threaten HIV care? Yes, if we don't plan. Let us plan. If we don't plan, we are going to kill our clinics. The benefits are enormous. Improved access, enhanced quality of care, reduced stigma, cost savings. We're going to change the 50-30-30. And integration does not really, if you do a good job, it doesn't mess up what we have done.
As we look towards integrating HIV response in the health systems space, please let's not forget to put communities at the center. Let's ensure that we put them at the center, and let's ensure that we build their resilience, because a lot is happening in the space. There's a lot of funding model cuts down. If we don't build these communities, then we can miss off our track targets. Thank you.
I think we need to, as we look at how to make this a more sustainable response moving forward, we need to figure out how to make sure that we're using the government's own strategies on universal health coverage and integrating HIV into that strategy. So PEPFAR provides HIV services really across the board, but we have, and we've been in Kenya for over 21 years. But as we came in in an emergency situation, and we are now moving to something that's much more sustainable. In doing so, we need to really make sure that those services, which are prevention, which are treatments, which are building health systems, are really much more integrated. And so we're looking at how to make sure that we're not just have a siloed response, but one that really truly is working together and is much better for the patient.
During the summit, one of the critical tool that was launched was digitization, e-tools, EDQA, data quality audit tools, really just adapting technology for the purpose of accelerating access, capacity building, which is, if you think about what will make integration work, technology is going to be important. And so one of the critical tools that was launched is around HIV, adapting e-learning, e-data quality tools, applications for the purposes of service delivery, which is important. The other tool that was is very critical is the elimination of mother-to-child transmission of HIV framework, which does look at beyond HIV, and it is aligned with the global guidance that HIV, syphilis, and hepatitis share their risks and the opportunity for elimination. And so even the tools are coming out as integrated tools, not as a standalone tool. So their intention is to really fast track some of the conversations we are having to move forward with an integrated response.
I'm grateful that as we reflect on the tremendous achievements we have made in terms of fighting HIV/AIDS and also helping those who are living with HIV/AIDS, the Department of Health has done quite a great job. And today we have identified 87%, we are at 87% identification. That means we have been able to move to the rural areas, move to different areas in urban areas and other places, schools and other facilities, and we've been able to identify 7% people living with HIV/AIDS, realizing that this is a very important step because you cannot begin the treatment and management of HIV/AIDS without really knowing or having a scope of those who are living with the same for proper management.
Going forward, because we have built the capacity within our institution, our health department, our workers are trained, that we'll be able to deal with this with our own internal resources without necessarily getting external support in the long term.
The attendees, the delegates attending this conference, your active participation, your engagement and contributions have been pivotal in making the summit a vibrant platform for the exchange of ideas and learning.
It's been a very good learning session or summit. Yes, and we are happy that it brought perspectives from various quarters, from different counties, implementers themselves. We had communities who are beneficiaries of services. So we had the managers at the counties, and that's why you see us here. And also we had experts from institutions, research institutions, institutions of higher learning, and also the ministry, other government bodies, and also international bodies. So it's been a very good cross-learning session. This is one of, I could call it a best practices conference where we learn from each other, all right? And of course, the partners who came on board to support all this, we need to thank them. PEPFAR have been with us for too long, Global Fund, and we're seeing the transition from a thinning disease, how it was called before, to where Kenya called it a national disaster. We're now talking epidemic control, and now the story is so sweet. We're talking transition. But we have to be very careful because the gains are so fragile. We might lose them. We have to look at a way of how we transition, how we integrate without losing the game.
I urge all participants to actively engage in discussions and contribute to shaping the future of HIV service delivery. Let us have a collective commitment to achieving the ultimate goal of ending HIV pandemic and ensuring health and well-being for all Kenyans.